Friends, good morning. So, welcome back again to this high-tech workshop in the high-tech city. So, we are now in the third session, post-inauguration. Dr. Arjun Srinivasan doesn't need any introduction. He is working with the Royal Care Super Speciality Hospital at Coimbatore. And just now, Dr. Muthu has shown that in the entire country, there are 7 cities which are on the top in doing the interventional pulmonary procedures. And Hyderabad and Coimbatore are 2 of these in the 7 cities. So I request Dr. Arjun Srinivasan to come over and then talk on a very important topic. When we were doing our MDs, when we were trying to do a biopsy or a needle aspiration, we were very, very careful not to get into a blood vessel. But now Arjun Srinivasan is going to talk exactly that, how to get through the blood vessel and into the tumor. Dr. Arjun.
Thank you, sir, and thanks again for the invite. And over the next 10 minutes or so, we'll look at what is EBUS transvascular needle aspiration, and should you do it, and if at all, then when you have to do it. So, like sir rightly said, not initial days of EBUS, the training, or why EBUS came about, when we were doing conventional TBNA, is a lot of times where we think we look at the CT, read it, and once we poke the node, you find all you get is only blood. So our main aim is to actually avoid both the vessels, which might be intranodal as well as extranodal. And this is done as far as intranodal is concerned to prevent contamination of smears. We discussed in detail today that once you have all blood, then it will be difficult to ascertain what are cells inside. And extranodal for the fear of mediastinal hemorrhage and complications related to that. So if you look at that, basically, this is again going back to, I'm sure this slide would have been projected yesterday. You have vessels all around whenever you are inside the tracheobronchial tree, and there are certain lesions which are traditionally considered to be inaccessible by a convex probe EBUS, which is the station 5, 6, 8 and 9. And these are the nodes which you'd say that, okay, you'll have to find an alternate way to diagnose these lesions, or no, this cannot be done by a convex probe EBUS. So what is ebus-tbna, which is transvascular needle aspiration, which is both trans and intravascular. So when the EBUS needle is taken across a vessel or into the vessel on purpose to sample something which is there inside the vessel or on the other side of the vessel. So when it traverses completely, it becomes TVNA. When it is inside, it becomes intranodal aspiration. So the whole process needs to be under ultrasound vision. So you need to see what is going on. Otherwise, you don't know. Then it becomes a blind procedure. So which are the vessels which have been sampled across? You have sampled across aorta, main pulmonary artery, branch pulmonary arteries, brachiocephalic arteries, SVC, azygous vein, intracardiac and intrapulmonary artery. So what are the indications for ebus-tbna? So when you look at the indication, when you have exhausted all other options. So that will be the most important indication, as that you have exhausted everything else. The diagnosis is not achieved from more accessible lesion. So if you have a more accessible lesion which can either be taken by EBUS or an EUS, you take that and try to get a diagnosis. When the transvascular, or when transvascular lesion is the only one. So you do not have any other lesion to sample, and you can only sample the transvascular lesion. Or if the patient is unwilling, and you feel after a discussion that the patient is unfit for other options. So if other options either are more invasive, or you feel that the patient is not willing for other options, and for staging purposes. So sometimes you can have a more accessible lesion, but this needs to be accessed so that the patient can be staged appropriately, so that appropriate further treatment can be initiated. So what are the various aspects to a transvascular needle aspiration? So there are operator related aspects, scope related aspects, needle related aspects, and of course procedure related aspects. Operator related is obviously this is going one step higher, like we talked about in case of biopsy. This is not something that is routinely done, it's an off-label indication. So you need to be experienced in doing EBUS per se. I'm sure the second point is editorial, but at least you need to have few procedures under your belt, the significant number, and regularly doing. So it's not only about having done 50 or 100 procedures, you should be doing it regularly so that you have the muscle memory to do it. And well versed with all the anatomical landmarks as you would see it on an ultrasound. So it is, you should be able to make out which vessel lies where. So what are the scope related aspects? So basically we have three major scopes. If you look at the Olympus scope, I want you to concentrate on this. The field of view. Field of view is the field of view of what you see, the conical thing that you see as far as the ultrasound goes. The wider the field of view, the more you will be able to see. And if you are targeting nodes which are about 1 to 1.5 to 2 centimeters, usually the field of view does not matter. But if you are doing something more, like if you are doing a transvascular access, then the field of view will start to matter. So if you compare a field of view of an EBUS scope versus an EUS scope, the EUS scope has a much larger field of view as against a EBUS scope. If you see, as compared to a Olympus scope, a Pentax scope has a much wider field of view, and when you move on, the Fuji scope has even wider field of view, which is up to 120 degrees. If you look at Olympus needle, so basically there are, Olympus is the most commonly used needle, and here what you need to look at, one is the size of the needle. So you got 21 needle, you got 22 needle, and you got the 19 needle. So most of the studies have used either 21 or 22 needle, and here what you also need to see, you're looking at, if you're looking to go across a large vessel, say if you're looking at either an aorta or a pulmonary artery, you're looking at something which is about 2.5 centimeters. So the amount of needle that is available for you to work with also becomes important. So that is where the maximum needle length with the Olympus needle is about 4 centimeters. That's the maximum the needle would come out. As against if you use a Boston needle, the maximum needle length is 8 centimeters. And if you use a Cook needle, it is about 5 centimeters. So needle size, again, like I said, most of the available studies have been on 21 and 22 needles. Some have reported using 25 gauge needle, and there has been one case report with the use of 19 gauge needle. So procedure related, of course, these are all things that you need to look at. Anesthesia. So normally a routine EBUS can very well be done with the patient with IV sedation, and a lot of centers do it. We used to do it, the first 1,000 and odd cases we did it only under conscious sedation, and over a period of time we have changed. Most of our patients we do it under general anesthesia now. But if you want to have a precise, you don't want the patient coughing at the most inappropriate time if you are trying to go across a major vessel. So it is ideal if the patient would be under general anesthesia or at least more deeply sedated than normal. ROSE, again, so ROSE and the next question, the next point will be related. So if you can have a ROSE, I know that having a ROSE would increase the time between two passes, but it can technically reduce. Again, you're looking at only case reports and case series, so you would not be in a position to say that this is how it has to be done. But having a ROSE in this setting would really help you reduce the number of passes, because once you have a positive diagnosis, then you can stop the procedure. Specimen processing, again, we talked about it in detail in the morning. These specimens are really precious, and you need to have it sorted with your pathologist as to how do you want to process these specimens to make sure that you get the maximum yield out of whatever aspirate that you're getting. And now we'll look at the yield and complications. So passes, like we said that we want to reduce the number of passes. The largest study is about 35 patients where most of it has been done across this one, and they have averaged a pass of 6.7 passes per patient, and the maximum number of passes that they have done is across the azygous vein 15 passes. So this is this is what it is. So it is intuitive. Most of the time when we have never done more than a couple of passes, and but this is what has been reported in the literature. So this is the largest study, 35 patients. So this would be the study where we can look at the complications also. 35 patients where they had 4 of them had significant post-procedure complication, one was a mild hemoptysis, one was a moderate hemoptysis requiring epinephrine infusion and saline infusion, one was an acute exacerbation of COPD, and one was a rapid ventricular rate. But the paper went ahead and said that the patient who actually had a moderate hemoptysis, they did only 5 passes, and the patient whom they did 15 passes did not have any, So according to them, they say that the number of passes probably doesn't matter, but again, it's a small study to actually draw any conclusion. Their overall yield, again, you'll have to look at, like we said with biopsy, it means that just because you're going across the vessel does not mean that you're going to get diagnosis all the time. So this would probably be, since this is the largest study, this would probably be the study where you say that you can probably achieve diagnosis in about 80 to 90% of the cases that you would do in ebus-tbna also. But again, since we are always scared of the number of passes, the yield might be suboptimal as compared to a usual ebus-tbna. So let's look at some case scenarios. So this was something that we did way back in 2012-13, and middle-aged smoker. Again, this guy had an accessible 4L node, but multiple passes were negative. He had pneumothorax and necrosis when they tried to do a CT guided biopsy. So this is the, you can actually see the aorta, and this is what I'm talking about when in terms of in terms of the field of view. So the field of view is quite narrow because we are using the EBUS scope, and again this is the first generation EBUS scope that we had. This is probably the only EBUS scope that was there in India, and subsequently they went on to EU MB1, and you can actually see that it's almost 2.9 or 3 centimeters is the diameter across the aorta, and this is actually the transaortic puncture itself. So you can see the once we have measured, you can see the needle actually coming through. And again, when the field of vision is narrow, you cannot actually see the distal end of the needle very clearly. You can see that it is, and when you take the needle, you will have to take the needle through. And this patient, because it was way back, this patient actually was done under conscious sedation, not under general anesthesia. So you can see that the needle has actually traversed the aorta and it has gone to the other side. And then again, we did only a couple of passes. And we see these, the couple of times that we have done a transaortic, we see this curious looking artifact which goes along the needle once the needle is taken through. So this patient had diagnosis of adenocarcinoma. This and one more case we went ahead and presented in way back in 2014 in I think ERS it was, and so this is patient, again enlarged lymph node, station 4L, station 11L and 5. This procedure courtesy Dr. Ravindra Mehta. And everything else was negative. So you can see that going across the pulmonary artery, and you can see that the needle is being taken across the pulmonary artery, and you need to have the entire needle out. And this is being sampled, and this was a granuloma. This was an interesting case. This patient, what you are actually seeing is puncture into the puncture into the pulmonary artery, and this was a pulmonary artery sarcoma that was there.
Sorry to interrupt, another 2 minutes.
Yeah, sure. So there are very scant papers, and most of them are EUS. And there was some 10 patients on pulmonary sampling, which is diagnosis achieved in 9 out of 10. and this again was 9 out of 10. So this was something that both of our centers collated the data and published, our center and Dr. Ravi's center. And this was again 10 patients. We called it TIPNA, which is trans and intrapulmonary needle aspiration. And again, adequacy was seen in and definitive diagnosis was made in all the 10 cases. So this was again from that large paper where they have gone ahead and sampled the station 3A node across the SVC. And again, from Nagarjun's team, they have gone ahead and done an intracardiac aspiration. This was the first EBUS procedure to do it. So they looked at, there have been a lot of, about 10 or 11 reports, most of them EUS. And again, they have gone ahead and used anywhere between 22 to 25 needle. And there have been 2 cases where 19 gauge needle was used. So, of course, what are the precautions that you need to know? The general precaution, hypoxemic patients know. Anticoagulants and antiplatelets, the patients have to be off, and the coagulation parameters have to be looked into in detail. Transaortic, you'll have to be careful about aortic calcification because most of them will be elderly patients. You'll have to avoid patients with aortic calcification. Transpulmonary, you'll have to be aware of patients with moderate to severe PAH. Intracardiac, you'll have to be look at whether the patient has history of arrhythmias. Complications, bleeding, mediastinal hematoma, hemoptysis, all have been reported. Major vessel rupture is something that you don't, that's why you want to have the patients under sedation and you want to avoid where you have an aortic calcification. Heterogeneous spread of infection, especially if you're doing it in necrotic nodes and multiple passes, and you're doing it in patients with suspected tuberculosis, this is always there. And of course, inability to achieve the diagnosis. So summary, it's an important tool to have. Operator must be experienced and indications are limited, and you need to have an MDT as well as you need to talk to the patient, get the patient's consent that what you're doing is off label, and patient needs to be informed regarding the risk as well as benefits. Contraindications have to be ruled out and the team needs to be geared up to manage complications. May not always achieve diagnosis because the diagnosis yield is likely to be only as much as EBUS and not higher. Thank you.